leadership. Let me ask a few opening questions, and I'll yield to my colleagues for any questions they might have. In reading the action plan, and you talked about it in your testimony, your written testimony as well, it does talk about, and you mentioned it, the 3 venues that will be held, Japan-led, UK-led, and Canada and French-led. Are there dates yet for those?
I am not aware of fixed dates.
You also note, in the action plan, it calls upon WHO and OECD to identify dementia as an increasing threat to global health. Now, as we all know, the Director General of WHO is there, Dr. Chen, and I'm wondering, have they been? Has WHO made this a serious part of their portfolio, or are they on the threshold of doing so? Because they have done some reports in the past, and I've certainly read them, and I know you have as well.
I do not know further of any action taken by WHO since that important statement at the G8 summit.
Okay. So that will be an ongoing case of advocacy on our part to ensure.
Certainly we play a role as we do in WHO affairs, yes.
Now in the list of action items, it talks about the UK establishing a new global envoy for dementia innovation. I wasn't sure what that was. I looked, and I'm not sure. How do you define that, or how do they define it?
The intent here, as best I understand it, is that the UK will identify an envoy whose responsibility will be to attempt to correlate public-private international partnerships towards a common fund of resources in support of Alzheimer's research. And I think that outline is the extent of the notion to date. UK will appoint. The rest of the nations were in full agreement with there being such an individual to take the lead in collaborating international public-private partnerships.
You know, we were all thrilled that the G8 is doing this and the UK did initiate it, but I'm wondering if there's any thoughts to expand it to the G20 and then by extension the rest of the world. Brazil, China, India, Mexico, South Africa, large populations, obviously with large numbers, increasingly large numbers of dementia cases who make up G20 but not G8. Is there an effort to try to bring them into the fold?
Absolutely. As you saw in some of the examples that I cited, there was international representation far beyond the G8. Our plans for the G8 legacy meeting, in fact, will call for invitations far beyond G8, and there are many more nations than that currently involved in Alzheimer's research who are being asked to contribute to this ontology database I mentioned. But without question, G8 was a very important set of leadership nations, but all of our international efforts will extend far beyond that to far broader international partnerships.
You know, one of the bullets in your testimony is increase the number of people involved in clinical trials and studies on dementia. Obviously, domestically, that will include African Americans. It will include all people from every ethnic group in all of the G8 countries. But is there any effort to try to include Africans and those who might not usually be part of these trials? Because we've been noticing, especially where longevity is now becoming a positive statistic, people are living longer, obviously, that we're going to see a huge epidemic of dementia, for want of a better word, in places like Africa, with a decreased ability to cope with it.
The challenge, if I can summarize it quickly, in carrying out the kinds of intervention, clinical trials, which are currently happening, is that the greatest emphasis is on analyzing people who are at high risk for disease long before there are symptoms of disease and tracking biomarkers such as through brain and neuroimaging, genetic analysis, and so on. It is currently challenging to do these kinds of studies, tracking such markers in nations that do not have the infrastructure for that kind of imaging. The way in which we are trying to do, though, is illustrated in one study to attempt to maximize this. This is a study looking at individuals with early onset genetically determined Alzheimer's disease due to a specific mutation. They have brain change detectable decades before they have disease. There is the largest familial cohort of these in the South American country of Colombia, which is relatively less developed in terms of its biomedical research infrastructure. So in this case, NIH, together with partners, are supporting studies in which those individuals will be studied both through establishing capacity in Colombia and through travel to the U.S. as one of the examples I can cite in which a generally less well-developed country can be supported for research as demanding as it is in cases where this is particularly important to the research effort.
You testified that the International Genomic Alzheimer's Project has discovered 11 new genes connected with the condition. How will these discoveries advance identification, prevention, and treatment of Alzheimer's? And with the collaboration that now has gone into a much greater area of cooperation, have we already seen some things that we were not aware of coming out of some of the other, the other countries that are part of this initiative? Are we saying, hey, we didn't know that, give us the information on that?
Well, in fact, the information that led to the description of these 11 new genes came only when we were able to look at enough subjects with and without disease that could be provided by international investigators. No single country, no single population of available data had the power to identify these new genes. You asked the very important question about what happens next once we identify genes as risk factors. An important observation of the genes described so far is that they tend to fall into families or pathways, many of them related, for example, to inflammation, others to transport of membranes. When we have these clues, this drives the next generation of research, which looks at ability to intervene and change the variables that are determined by these genetic risk factors, and to look for clues that these are targets then for eventual clinical intervention. This is a difficult and challenging road, but each one of these new genes and gene pathways we identify provides a new potential target for next efforts at intervention.
Let me just ask you one final question with regards to money. Are we appropriating sufficient amounts of money for research for Alzheimer's, and are the other countries doing likewise? It seems to me that one of the greatest models we have is PEPFAR in terms of the United States led, and other countries did indeed follow, and now the whole world is on the same page trying to mitigate the scourge of HIV/AIDS. And I'm wondering if this G8 summit was the catalyst, and whether or not we do indeed have a Manhattan-type mindset to really eradicate or at least find a therapy for dementia by 2025.
Well, I think it's certainly clear that the scientific opportunities that we have before us in the areas of Alzheimer's research are vast, and that the current fiscal constraints that we have are without question providing an important determinant in what research we can carry forward. We're gratified by the additional funding in 2012 and 2013, which added to our ability to carry out important studies. We're hopeful that there will similarly be increased in funding available. The scientific opportunities, I think it's fair to say in direct answer to your question, far exceed our current ability to fund all of the meritorious ideas, and we remain committed, understanding the reality of fiscal limitations, to doing the very best we can with resources available.
I know it's perhaps a difficult question for you to answer, but could you give us any kind of sense of how many laudable projects fall off the table because they cannot be funded because there's insufficient funding?
I can give you just an overview in the sense that currently at NIA for Alzheimer's research, as for all of NIH, the success rate for applications is in the range of 15%. I think there is, of all applications received, I think there's wide agreement that meritorious, outstanding applications are fairly uniform through nearly double that amount. So one could safely say, if we did no more than fund all the meritorious applications that we had before us, even without taking measures to more actively solicit additional applications, that we could fund twice as much research as we are currently able with the resources in hand.
Do you have hope that the G8 summit will produce a catalyzing effect of, I mean, we saw it with HIV/AIDS. Once the bidding war, in a positive sense, started, countries began to step up to the plate. The Global Fund swung into action, and in every aspect, it was like, we're going to resolve this. We're going to stop this pandemic, as Henry Hyde called it, the prime sponsor of the PEPFAR program. He called it the Black Death of modern times. And it wasn't until that started that we moved into a situation where real resources were being brought to bear. Do you think the G8 summit may have had that?
I think
have that consequence?
What I can say comfortably is that we have an enormous responsibility to show in the abstract and also in specifics that there are scientific opportunities before us that are likely to provide the kind of progress necessary to achieve this goal of intervention and cure by 2025. I think that the G8 summit was a landmark in that it brought together scientists who could make the very specific case with specific plans underlying those aspirations, and that this was embraced, as you saw, by the common goal across nations. having met, I think, the important obligation to show that there is a real plan in hand with a rational approach to conducting research that will take us to the goal in mind, I think we now stand and are hopeful that policymakers will take maximal advantage of the information we can provide, ask us to provide more than we can, and leave to your hands what we hope will be a translation of these opportunities into research and real progress towards that goal and timeline.
Thank you, Dr. Hodes. Mr. Weber.
Gosh, I don't know where to start. Dr. Hodes, you said in Columbia you had